You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're going to be speaking about improving cardiac arrest survival rates with Mark Faulkner. So despite advances in pre-hospital care, cardiac arrest remains a major challenge, with survival rates varying widely depending on early intervention, high-quality CPR, and system-wide coordination. So joining us is Mark Faulkner, who is no stranger to the podcast. He is a leading expert within resuscitation. He's a consultant paramedic. He's also an associate medical director. And he is going to explore with us the key factors that influence survival rate, from bystander CPR and public access defibrillation to high-performance CPR and indeed post-ROSC care. We're also going to discuss some of the innovations in the market, but also the role as we play as clinicians within the system and how we can really approach system-wide changes to make a real difference to patient outcome. Mark, welcome to the podcast.
Hi, Owen. Thanks for having me back.
I just wonder if we could kick off, Mark, and just really, as a framing question, really just understand the problem. If you could maybe speak to some of the biggest challenges we currently face in improving out-of-hospital cardiac arrest survival rates.
It's probably helpful just talk a bit around where we are in terms of numbers. Come no secret to people who listen regularly, I work in the London Ambulance Service. We're a pretty busy ambulance service, somewhere around 10 to 12,000 cardiac arrests each year, depending exactly how you manage it. Last year, 12,242 with a kind of active resuscitation rate of about 4,572. Those are just approximate figures off the top of my head. I might be a bit sad about this. The bit that's interesting with this is if you look at survival figures and you look back 10 years, so go back 2014, 2015, overall survival figures, 9.4% in London. We've had some years where we got a bit better. We got up to 11.4%. In 2018, 2019. We then took a bit of a dip during the pandemic and kind of went down to about 8.1%. And this year, I'm very excited, we're back at 9.8%. That's really awful, isn't it? That's dreadful. 10 years, huge amount of effort, and we've seen the percentage change in cardiac arrest survival by 0.4%. That really, really doesn't tell us anything. And again, if you look at the Utstein group, so this is the group of shockable cardiac arrests that are used as an international comparator. Utstein is an abbey in Scandinavia where they locked a load of cardiologists and intensivists and made them come up with an international definition and refused to allow them to leave until they had. It's my basis of Utstein. And the Utstein allows you to compare across systems. These are presenting shockable rhythm, presumed cardiac etiology, and what you've got in that group is survival rates back at 10 years ago at 32.2%. And then you look this year at about 30%. So we're really seeing 1 in 10 of the entire population survive, and around a survival rate of about 30% if you are in the group that we'd expect to survive. Best year in London, 2018, 2019, 38.1. So we're really struggling to shift the dial. And we've got 10 years of data, which is kind of showing we're really doing the same. And that causes me a problem because I don't believe that is right. And I think if you have a cardiac arrest outside of hospital, and particularly if you present in a shockable rhythm, so you've had a sudden interruption in cerebral blood supply, and you have some level of oxygen reserve within your hemoglobin, your survival rates have got to be better than 30%. And we've got to work a lot better. And we've got to work a lot better, not only as pre-hospital providers, but as society. And the often quoted statistic that for every minute you're without resuscitation, your chance of survival will decrease by 10%. Well, we all say it. I say it fairly frequently. But is it actually correct? A lot of that data is some modelling. And actually, if you look, and this is not new data, but DeMayo's group over 20 years ago looked at real patient outcome and actually said for every minute you're without resuscitation, your chance of survival will decrease by 22%. So a lot of this has to be around those first vital few minutes. And everything that we should do is about preserving cerebral blood flow and coronary blood flow through really good quality resuscitation, and then really optimal interventions to restart the heart. And I think it is always helpful to talk about the shockable group, because the shockable group who present in a shockable rhythm are the low-hanging fruit. They're the easy wins. They're walking down the street. They have a sudden arrhythmogenic event. They end up in VF. They lose cerebral blood flow. But up until that point, they had good hemoglobin saturation. They had an oxygen reserve. So you can pump that oxygen reserve around with good quality resuscitation, get blood to their brain and to their heart, and buy yourself some time. That is different from the group in pulseless electrical activity. And it kind of pains me when I talk about pulseless electrical activity being one group of patients, because it's really not. It's the end stage of virtually every condition. But often this is the group that is slightly different in that they are coming through a disease prognosis. They're using up their oxygen reserves, they're acidotic, they're hypoxic at the point of arrest, and they are more difficult. I don't believe survival in that group is futile, and I think there is lots that we should do in that group. But I think when we talk about society, our focus has to be always around the shockable group, because they're the easy wins. And we should look at what's going on in other places in the world to learn lessons, and we should really challenge about what we should do. I think that's where we start from with this.
Absolutely, Mark. And to your point, actually, because like you said, it's multifactorial. It is sequenced on the chain of survival, and there's some distinct groups in that chain of survival, and it's optimization in each, but also, like you said, prudent to look at the low hanging fruit as maybe not necessarily an easier, but more of a quick win to try and improve survival rates. But let's start with just on that journey of a chain of survival, because I'd like to dig into just that early resuscitation and recognition and bystander CPR. And indeed, what strategies could be utilized to improve bystander intervention rates, but also so that's the recognition piece, and then I'm going to come on to PAD, so public access defibrillator, and looking whether actually we've got, with 80% of cardiac arrests in the home, have we got the defibrillators in the wrong place? So, but let's initially look at that bystander CPR intervention rate. Could I get you to speak to strategies that we could employ to maybe improve that?
So I think it's again helpful just to understand where we are. So today in London, we see a bystander life support rate of about 65.5%. The best year we've ever had was 71.9. I'm academic enough to realise that you probably put those on a graph at 4,000, you're within the error rate. But if you go back 2010, 2011, 45%, 45.4% bystander life support rate. So we're heading in the right direction. But in a UK setting, we're not best in class. You look at Copenhagen, where there are reporting rates in excess of 80%, some bits of the States where you're seeing survival rates, again, high 70s, early 80%. So we've got to challenge ourselves about how we make CPR accessible within our community. And when I say CPR, I'm talking specifically about chest compressions. So how do we get to a point where chest compressions are routinely being administered? And how do we provide the confidence to society to do this? And I think there's a number of bits of it. Is that this isn't a one-hit wonder. There's no single intervention that changes cardiac arrest survival. But what you've got to do is take every opportunity. So we've got to ask ourselves and look really hard at the quality of resuscitation being taught in our schools. It's been part of the national curriculum for a number of years. But actually, are we teaching it in a meaningful way? Are school children leaving school confident to deliver these skills? And this isn't just CPR, it's also all of the other bits of first aid that many listeners to this podcast will know. It's not only how to press on somebody's chest, but also how to stop somebody bleeding, how to open somebody's airway. All of those bits that we all know will save people's lives. How do you teach that in a meaningful way? And how do we value those bits in formal first aid training versus other bits that get taught, probably where there is less importance. I always tell the story. Many years ago, I went and did a first aid course, and I was taught 19 ways to tie a triangular bandage on a 3-day first aid course, well before I was a paramedic. I'm now 25 years in pre-hospital care. I'm yet to save somebody's life with a triangular bandage. So actually, we've got to make sure the right bits of first aid training are being emphasised. And I think we're better than when I was doing my 3-day first aid work course. But I still think we're a little bit guilty about that, of actually, are we getting meaningful intervention, and are we teaching people to do this right at every available opportunity? Actually, is there a reason that as a society we do not expect everyone to hold a driving licence, hold an in-date first aid course? Could we say, actually, as part of your driving licence, you have a first aid certificate, and that has to be in date? You don't have to go to a classroom to do this. You can learn many of these skills online. There's lots of good ways of interacting. I am absolutely sure you could teach a lot of this through interactive learning online. I think some of the best training I've seen has been people learning CPR from videos, from computer games. I think that's all really important. And then how do we make that input in our schools meaningful? Should it be an examined subject? How do we get everybody who should be first aid trained doing that in a meaningful way, with the confidence that actually you're not going to damage somebody by putting your hands on the middle of their chest and starting chest compressions? Really challenging that. We've been doing some work, and the team here at LAS have done some phenomenal work in the last few years about teaching school children and getting into communities that have been historically where we've seen low levels of bystander life support. And getting, last year it will be about 6 out of the 700 school children last year. It's phenomenal, huge number. We'll have taught, coming up now, 12,000 school children since the programme started, in communities where we've really struggled to get bystander life support. But that's not a quick win. You don't teach somebody in a school in year 8 CPR and suddenly they go out and save somebody's life. This is about skills that we're equipping a generation. And that's very difficult, because you have to then be able to kind of say, we want to keep doing this, and it's going to take us years and years and years to get Londoners trained in life support. So I think we have to look at how we're training in schools, we have to look at how we're training in society, and then we need to build confidence about equipping people to respond. And I think that's absolutely key to some of this. And I am absolutely certain that the ambulance service will only take you so far in resuscitation, and this is about a resilient community that can help each other when somebody collapses. And yes, you want an ambulance there really quickly, but even better than that, you want somebody with hands on chest within 60 to 100 seconds of the collapse occurring. I'm a big fan of kind of community first responder programs that we've seen. They're hugely successful in bits of the UK. But we also need to look at what that looks like in an ultra-urban environment. I've just driven back from a meeting up in a hospital in London. It was a 1.2 mile drive, and it has just taken me 28 minutes to drive that. I should have walked. So actually sending somebody out in central London to the community that might be within a mile might be completely appropriate if you're in a suburban rural setting. But around here, you're not going to even make that. But we should be able to equip people to respond. We should be looking at people who could be a community responder in the estate in which they live in, picking up the defib and walking up that flight of stairs to the neighbour upstairs. So we should be doing all of that. And then we should think about low effort responding. And I talk about low effort responding in terms of community mobilisation. In the 21st century, we teach people when we teach first aid to shout for help. But let's use that shout for help and amplify that using technology. And the Good Sam app, which is the kind of software system in the UK that we use to do this, is just one of the examples, but by far an incredibly powerful tool that says, if you're trained in CPR and you're local, why can't we ask you to help? And people get very worried about Good Sam, and they say, well, but these are people who've only done a first aid course. Yeah, but that's all you need. Yeah. All you need to save your neighbour is to go around and put your hands on their chest. Oh, but what if it's not a cardiac arrest? Well, you've got to say to people, sometimes it won't be a cardiac arrest, and it's okay to put your hand on somebody's shoulder and say, there's an ambulance on its way. I'm just going to stay with you and talk to you until the ambulance turns up. People say to me, but these are members of the public, they're not professional responders. Yes, they are members of the public, exactly the same members of the public who do CPR if you collapsed in a supermarket. But what we're doing is saying, let's move and amplify that shout for help, that anyone can do it. And I tell this story fairly frequently. I live just outside of London, and my good Sam went off one day, and I looked and went, oh, it's just across the road. And I walked just across the road and started CPR on my neighbour who was in a shockable cardiac arrest, who now got ROSC, for an ambulance that was 15 minutes to arrive on the scene. This really does make a difference, really makes a difference. And you're absolutely right. You said, I think you said about 80% of cardiac arrests occur in the home. I think our figure in London last year was about 75% of cardiac arrests in the home. So let's put the response into the community. Let's use technology to do that. Let's break down some of the barriers around this. And actually, Copenhagen's a great example where they use a community responding system, have a phenomenal take-up of it, phenomenal response on it, and are seeing cardiac arrest survival rates hugely in excess of what we're seeing in London by just mobilising that community and having a society that says, actually, somebody around the corner from me has collapsed. Let me go and help. Let me accept that we're not always going to get it right, and you might sat there with somebody who's just fainted. But let's use that to alert members of the public who's done a bit of training, and let's not be scared to do that, because actually the training you need to save somebody's life is really quite limited. So I think we should absolutely focus not only on the training, but also how you then mobilise that training into society. And we've got to accept that if you want different outcomes, we're going to have to see some things done differently.
Absolutely. I couldn't agree with you more, Mark, actually. And to your point around enabling and reducing the friction, really, both from, and it's again multifactorial, but there's the early recognition and the early shock, both of which need to be enabled almost fundamentally by the community. And as you said, it's a team approach, which includes the community. And often sometimes makes me wonder whether the community really that are involved should fundamentally be involved in the debrief, actually, because they are as much part of that care team for that patient as the established ambulance service. But if I could just then come to, because there has been quite significant development on the established or indeed formative pre-hospital side. So we've started to see the adage of high performance CPR. We've started to see the adage of mechanical CPR devices. We've started to see the adage of ventilatory monitoring devices, which monitor the amount of ventilation and the sequence and how much and the tidal volume. And so we're starting to get a semblance of effectiveness and efficacy of CPR, both from reports, but also from mechanical devices and technology devices. Could I get you to speak to how far we still got to come to sort of optimize high performance CPR and some of the key components that actually do make the biggest difference?
So you come back to what are the interventions that make a difference to the patient, and that has to be high quality CPR and high quality chest compressions and prompt and effective defibrillation. Those are the things that when I have my cardiac arrest right now, I want somebody on my chest pretty much before I've hit the ground, and I want to defib on within that first 30 seconds. And what we need to do is focus about how we do that. And I think there is some interesting stuff as we begin to start thinking about, does video play a place in this? So in the 999 call, can you help optimize somebody's chest compressions? Move your hands up a bit, move your hands down a bit using a video prompt. Is there a way of doing video assisted CPR without delaying chest compressions? How do you get to the point within that 999 call that the hands on chest really quickly? And is it in fact that you start a system, and we've talked about this a bit, of saying, are you the only person on scene? If the answer to that is no, have they got a mobile? I want you to give me the address and I want them to phone. We could have another number. We could have 8888. Phone 8888, and you go straight through to a clinician who will send you a video link and start talking you through chest compressions. But what you don't want is to delay that chest compressions with somebody going, I need you to click on the link, and I need you to accept and allow and allow and allow. You've got to do it whilst also maintaining it. And you're right, there's a lot of technology change, and we spent a lot of time talking about how you optimize that resuscitation, making space, making sure the chest compressions are optimal. Where do you move to mechanical device within those chest compressions? I'm a big believer in all of this. It's around basics done impeccably well. Yeah. And I really, and I said this the other day, and probably at a meeting where I shouldn't have said this, we should stop calling basic life support, and start calling it life support, because that's the bit that makes the difference. And we should take the word out advanced life support, because it really is not very advanced. And actually, what the important bit is it's really good quality chest compressions. Now, if a mechanical device helps you do that, that's really important. But that mechanical device should not get in the way of a patient having a shock. And I've certainly, in my career, seen lots of what I'm going to describe as faffage going on with mechanical devices. And actually, what should have happened is the mechanical device should have been thrown out the window. And actually, you should have just done basic life support and had no interruptions. So I think it really is that, yes, these have a place, and they probably have a place in the patient who needs to move. But in that first vital 6 kind of plus minutes, the first 6 minutes, 8 minutes, 10 minutes of that resuscitation, that focus should all be on gaining ROSC, which should absolutely be on maximising cerebral and coronary blood flow. Because if you don't have cerebral blood flow, you don't have cerebral protection. And if you don't have coronary blood flow, you ain't going to get a ROSC. So you need to making sure you're doing really good quality chest compressions, and you need to get that initial shock in. And we talk a lot about patients being in the kind of the old language of the electrical phase of VF, the chemical metabolic phases of VF. You want that shock in whilst they're in that electrical phase. And you want that really good CPR and really good perfusion to maximise the chance of that shock working and making sure that you're protecting the patient's brain. So yes, mechanical devices have a role, but also I think you also have to remember what your definitive intervention is. And again, like many others, I spend a lot of time about saying, when you're running that resuscitation, making sure you've got space to you've got access to the patient. You don't want to be resuscitating somebody on the table. You've got to make yourself space to make that resuscitation optimal. Stuff I'm sure you said, Owen, when you teach this. But actually, probably the first thing you should do is walk in, put the pads on, and if they're in VF, give them a shock. Yeah. And then we can move the coffee table, and then we can get them on the floor, and then we can do everything else. But the vital bit that goes before that is you've got to get in and deliver that shock. So I think all of these things have a place, but I don't think any of them should ever be at the expense of what I'm now going to call core life support or essential life support, the bits that are absolutely what is needed. And yes, mechanical devices are great. I use them all the time. I'm a big fan of them, but they're also the right pair of hands. And somebody said to me the other day, I had a conversation with a partner agency saying, think about mechanical CPR for some of our units. And you go, how about you think about defibrillators for all your units? And actually, that's what will save somebody's life. And that's the bit that's really vital, is saying, actually, it's that hands on the chest. And how do you mobilise a community to respond to that? And I come back to this time and time again with no excuse. Actually, if you live next door to a fire station, could the fire brigade help you in the true cardiac arrest? As long as they're still there to put out my house when it burns down, if they are able to help somebody in cardiac arrest, that's really vital. Should we be looking at police response and co-responding through the police? They've got blue lights, they can get to somebody quickly, they may have a defibrillator, they can start CPR. Should we be looking at equipping commercial organisations? Who are some of the people who drive around our city centres? Lots and lots. Is it Uber drivers? Is it black cab drivers? Is it the Amazon delivery man? Can you imagine a system where you had a defib in every Uber? And everybody of those Uber drivers, as part of their taxi licensing, was trained to do CPR. Because literally, that is what has just caused my 28-minute delay driving from 2 miles in London. So actually, there's all of that about how do you equip a society to get that. And yes, we spend a lot of time talking about it, but you shouldn't distract from it.
Listen, I agree totally, and I think you're right. Enablers, such as making policy decisions and decisions in which there's a mandated component actually to allow and facilitate the freedom of education and of understanding around CPR. Mark, could I pivot slightly and look at airway management in cardiac arrest and ventilation strategies? There's been I'll get you to speak to the latest evidence if that's okay. There has been a significant shift, understandably so, of not over ventilating, so to almost put air into the stomach, and then that acts and impinges on the IVC, or indeed starts to prohibit effective chest compressions or effective blood return. And certainly I'm sure you can attest to sort of decompressing the stomach a number of times just to release that air so that there is free flow of blood back to the heart. But could I get you to speak to this, I guess in a way, this cultural shift of understanding the importance of ventilation? Once we've got the chest compressions right, once we've got the defibrillation right, just of good systematic ventilation, and indeed not over ventilation.
So I think the ventilation question is complex. And I think we don't yet know some of the answers. What does optimal actually look like? I think I constantly say this, is that nobody dies because they haven't been intubated, and nobody dies because they haven't had an IGL. What kills them is that they are hypoxic. And that's the bit that you absolutely have to balance, is what you need is some gas flow. And you can do that with a bag and mask. You can do that with a lump of plastic in the airway. It may be in those first very few minutes of cardiac arrest, we need just to perhaps do apneic oxygenation. And there has been some evidence around that, is that just squirt high flow oxygen up the nose in those first few minutes to give you some time to optimize the chest compressions. There is some interesting work going on around the world about mechanical devices and ventilation, and adjusting the mechanical device and the ventilator around synchronized chest compression ventilation, CSSV, so that absolutely you are making sure, because actually there may be some benefit in the lungs being slightly inflated, and maintaining a little bit of residual volume in the lungs, because actually if the lungs are full around the heart and you press the heart, it might help with your chest compressions. Equally, what you don't want is lungs hyperinflated and massive thoracic impedance. You certainly don't want gallons of air in the stomach. I think one of the things I constantly say when people talk about gastric decompression is be very, very careful, because if you lean on somebody's stomach, which is how people talk about doing this, and you haven't got a secured airway or just a supraglottic, you're very likely to make the patient vomit or regurgitate, and that makes a whole world of pain. So actually, I think there is something, if you're using an advanced airway, use gastric decompression. But outside of that, probably not so much gastric decompression. But I think the question is a little bit more complex than we think. And I think it is about not worrying about the lump of plastic initially, but making sure you're ventilating the patient. And remembering that there is a skill in a lot of this stuff. Putting supraglottic airways into patients is relatively straightforward, but you need to be absolutely confident the airway is clear before you put that in. Those of you listened to me before, I spent a fair amount of my time studying coroner's court, and Mark has a list of things that have appeared from below a supraglottic airway. Later found at inquest, you never want the pathologist phoning you, telling you, guess what you didn't find in the airway. So that is it. They are straightforward, but you've got to be sure the airways are clear. And they probably are more helpful than a BVM in cardiac arrest. But you also need to make sure you're moving the chest. Intubation in cardiac arrest, is there a role for it? I think there probably is. There is some evidence and some emerging evidence. So some patients who get intubated are doing a bit better. But those patients who tend to be in that bracket are being intubated by incredibly high performance systems who are making sure that tube is not only in, but there is no interruption in chest compressions whilst you're doing it. Intubating somebody on the floor with a mechanical CPR device going is very much a skill, and it's not a skill that unless you are doing routine pre-hospital cardiac arrest management, you will develop. It's not a skill that often is maintained by our colleagues who work in a hospital setting. So I think there are bits around ventilation and how you tweak that. I think the jury is still out a bit. I think moderate ventilation, making sure the chest is moving, but not hyperventilating or hypoventilating, is vital. But certainly in the first few minutes of that cardiac arrest, the focus should be on prompt defibrillation and effective chest compressions.
So let's move slightly towards post-ROSC care. I'd like to ask you about the role of ECMO. We'll get down the line to that. But just in post-ROSC care, there has been a general shift, certainly within the UK, but also globally, in the use of post-ROSC adrenaline for the unstable cardiac arrest. But as Paramedic 2 trial showed, a slight improvement in 30-day survivability, but actually no long-term benefits, and actually potentially worse long-term neurological outcome with the use of adrenaline or the wider use of adrenaline. Could I get you to speak to what we're seeing within post-ROSC care and indeed the role of adrenaline as it currently stands?
So I think the first thing is, let's talk about Paramedic 2 and let's talk about exactly what that did tell us. I think one of the things that's always, we talk about studies, and it's always helpful to go back and ask what was the question the study was asking. And if we go back to what Gavin Perkins and the team did from Warwick, it's in adult patients with an out-of-hospital cardiac arrest, does the dose of adrenaline, does the administration of epinephrine compared with placebo improve survival? That was what the exam question was. That's what we were trying to answer in the study. This isn't about post-ROSC adrenaline. This was about intra-arrest adrenaline. And again, it's helpful to just look at what the primary outcome was. And the primary outcome was survival at 30 days in the epinephrine group. And in the epinephrine group, you saw a survival rate of 3.2. And in the placebo group, a survival rate of 2.4%, with an absolute risk reduction, an AAR of 0.89%, with a confidence interval. And that's statistically significant. And that's the first thing. So in a study that looked at this, their primary outcome in a huge study, was that adrenaline improves survival. We then went on and looked at secondary outcome measures in terms of neurological function. And it is probably also worth remembering that the reason we do statistical significance in studies is look at effect and look at taking out chance. And what we saw in the survived group was a non-statistically significant increase of poor neurological outcome. So this could be chance because it's not statistically significant. And it was a very moderate change. But it is there in the data and we should look at it more. But we also have to remember that this is a study that looked at 8,014 people off the top of my head, I think, of which 7,790 died and 224 lived. There are 194 survivors, I think, in the placebo group and 130 survivors in the adrenaline group. And we saw a small outcome difference in terms of severe disability in the adrenaline group, worse. There are lots of discussions you can have, and clearly we could spend an entire day, and others have, talking about this study. But fundamentally, if you have more survivors, you'll also have more increased neurodisability. That's a factor of increasing survivors. But there may be something behind it. The NNT in it was 112, I think, was to give adrenaline. So the first thing to say about this is you really don't want to get to the point of a cardiac arrest where you require adrenaline. If you're unlucky enough to have a cardiac arrest, probably the exact focus needs to be on getting ROSC before we start giving you loads of drugs, because an NNT of 112 is quite awful. So let's be straight about that. The absolute with this is you don't really want to have adrenaline. You don't really want to have a cardiac arrest, but you certainly don't want to have adrenaline, because your outcome at that point, simply because that occurs quite late into the cardiac arrest algorithms, particularly pre-hospitally, is not positive. Now, we talked about, the question was about post-ROSC care. And yes, we use adrenaline, and I think what simply happened is the pre-hospital care community has caught up with the in-hospital community, and we're now using small volumes of drugs to manage and sustain the ROSC. Now, clearly, if you have a level of cardiogenic shock post-ROSC, you will do worse. But do I think adrenaline is harming that? I don't think it is. I think there is a balance between perfusion and increasing myocardial workload at a very simple level. And I think adrenaline, along with other drugs, may have a role in managing that patient in cardiogenic shock post-arrest. Now, clearly, we come back to, if you've had a cardiac, unlucky enough to have a cardiac arrest, you would like to get shocked out of your VF and have a normal cardiac output. But if you don't have a normal cardiac output, you need something that's quick, easy to do, manageable, and adrenaline does fall into that bracket. We can debate inotropes and choices of inotropes, and you can get somebody far more eloquent from an ITU background to talk about which inotrope is which. But the advantage of adrenaline is it has familiarity. Most of us are highly familiar with giving it in the post-ROSC patients, and I think it does have a role. But I think it is about management of that patient into definitive care. And I think one of the things when I talk about this is these patients in the main never normally have normal numbers, and you shouldn't be aiming for normal numbers. What you're using is this as a bridge to get somebody to definitive intervention.
Well, could I get you to speak to post-event debriefing, or indeed post-cardiac arrest debriefing? It again, from a cultural perspective, it seems to become more normalized, which is fantastic to see, actually, because I think you said this on another podcast, but any semblance of high performance needs and requires feedback, both from a critical care practitioner, but also to the wider team and back to the critical care practitioner, so that they are equally as informed about their performance. But could I get you to speak to post-event debrief, and indeed how it started to redefine how we think about cardiac arrest management?
So I think this is pre-hospital care catching up with many other areas of clinical practice, but also with very other areas of society, that if you want to learn and improve, you've got to ask for feedback, and you've got to invite that feedback and do that in a structured way that we can absolutely make sure that we're getting that and that we learn from it. Because the only way you don't make mistakes is you die as a clinician. Yeah. And if you haven't made mistakes, you've either seen not enough patients, you're amazing and wonderful, and I'm yet to meet you. So actually, we should completely invite that. We should do that in a structured way. I think we have to get a balance with all of this. And I think as an individual who leads these, you've got to think about what your learning points are. You've got to do that in a concise and considered way, both in terms of the emotional well-being and the kind of resilience of the team, but also in terms of what is a reasonable learning point stood in the back of an ambulance at 3 o'clock in the morning. And I think one of the things I think we've got much better at doing in an ambulance setting is that kind of hot debrief, immediate after action review, whatever you want to call it. I think we've still got a way to go about coming back as that team and saying, let's revisit this. We can do this with technology. We can do this even remotely and say, actually, what are my capsule learning points? What would I do different next time, having had an opportunity to reflect on it? And I don't think we're quite there with that yet. I think the steps we've made are huge. And certainly in my career, the kind of concept of actually stood in the back of an ambulance, even talking after a job, that wasn't about where you were going to get your coffee or what was the best kebab van open at 3 o'clock in the morning, is a really positive step. But we shouldn't stop striving, and actually we do need to the next step and say, how do I cement that learning? How do I reinforce that learning? And how to bring that back? And I think post-event review is really vital. And you look at some of the highest performing systems in the world, and some of the stuff they do immensely well is they look at their defib downloads and they look back at that record and say, why were we off the chest for 2 minutes there? what was that gap there? Why is it taking us 40 seconds to get back on the chest? Might have been because we're moving the patient to space, but it might be that could we have done that quicker? Was there another option? And looking at the objective evidence, we've put a mechanical device on, which is taking us 30 seconds and no flow time to put the mechanical device on. And when we put the mechanical device on, the end tidal CO2 is still the same. So clearly, or it's fallen, clearly that's not optimized chest compressions. So actually there's all of that. And I would love a system in the UK where we have somebody looking at a cardiac arrest in forensic detail from start to finish, and we say, what is it that we could have done differently? And doing what we've done a number of years with trauma and saying, who are the unexpected survivors and who are the unexpected deaths? And learning from that. Why did Owen survive that cardiac arrest that day, but somebody else hasn't survived it? And really driving on that performance, change.
So Mark, let's talk about ECMO, because you are absolutely embedded and involved in ECMO pathways now, and it seems to be, certainly within London and a metropolitan context, starting to become established within both within a pathway but also within parameters of acceptance and hopefully some semblance of 24/7 service. But could I get you to speak to whether you see it becoming more widely available and whether you see it becoming almost a trend that is replicated or replicable outside of the big urban centres?
So you can't ignore evidence. And the data out of Minnesota and Demetrius's group in Minnesota is really convincing that we perhaps should be looking at this. There is some interesting stuff going on in Holland, Sydney. We've got some really interesting work. And we're plodding away in London, as well as this kind of Prague data and bits like that. So there's some data which you can't ignore. But it's not a magic bullet. There is a group of patients who I think mechanical support in cardiac arrest might be the future. However, extracorporeal support is available in very few centres in the UK. If you look at London, we have 3 centres that offer mechanical support, all within about 4 miles of each other in central London, and one right on the peripheries. That doesn't serve the population. What I think we know is that time is absolutely vital, and that, yes, mechanical support is helpful in the refractory cardiac arrest of increasing the time of cerebral perfusion. So effectively, mechanical CPR simply is allowing you time to find out why the heart stopped and restarted it, or mechanical support and ECMOs, that's what that does. But getting the patient either into that centre or from that intervention to scene in a meaningful timeline is difficult, and it's not straightforward. Also, there is challenges around patient size, how easy it is to place the cannulae, how can you do that and then extricate the patient once they're on cannulae. Those are all challenges, and some of listeners will have read sub 30 in our paper recently about the experience of doing this pre-hospitally, very small number of patients. I think all that told us is it's possible to do it safely pre-hospitally with a highly skilled team. What we do know is we have a direct ECMO pathway for advanced paramedic practitioners in London, but the number of patients we can get into that pathway is low. It isn't an equitable service, and we've got to work to address that, and we've got some plans going on about how to address that. But you can't ignore that this might be an intervention for a number of patients, but it's also not an intervention for every patient. And I think it's always really helpful, and I say this constantly, is for all the time we spend concentrating on this, we need to be putting at least quadruple that amount of time into getting the basics right. And every conversation I have about ECMO, I also have to remember 2 things. One of which is, if a colleague of mine was sat here, he would remind me that turning up with 2 large pipes and putting them in somebody's groin is an awfully good way of distracting people from actually doing a really effective resuscitation. And that we always should be focused that actually we are not distracting from those potential life support interventions. And the second of which is this is also a very expensive intervention. And as a society, we have to make decisions about where we put our healthcare money. And actually, for every patient you put on ECMO, which I do believe should be part of a pathway, you also have to think how many defibs could that, or how many school children could that train in CPR, and when you're making decisions about finance. And I think we've got to do both. We've got to look at high intervention strategies and targeting the right patient. But I'm absolutely sure what you don't want is an intervention that is distracting from getting that really early ROSC. And what you probably have to do is create a balance between the extricate to ECMO versus I want to get ROSC on C. And I don't think we yet know where that dial sits. Is it at 15 minutes? Is it 20 minutes? Is it 10 minutes? That's difficult. And I think you've got to, and again, we have an idea, we talk about getting people on ECMO and pump within an hour, but do we really know that? Yeah. Is that too short? Is it too long? Should we be pushing that timeline? What are the factors that allow us to push that timeline? And then what are the interventions that might help us bridge to ECMO? Are there things that you can do that are not as hyper-invasive, that are more easy to scale and deliver than a huge pump? And they tell me the pump's very small, it's not, it's huge and very heavy. But how do you scale that? And are there things that you might be able to do? And some of the work about aortic occlusion and balloon occlusion of the aorta and cardiac arrest is interesting. But how does that fit into that? And does that allow you to bridge somebody to more formal mechanical support?
So, Mark, just as we come into land in the conversation, could I get you to speak to just a national registry for cardiac arrest, and indeed if there's any improvements within national data collection?
So we have a national, in the UK, we have the OCA registry run by the team at Warwick. It is a massive step forward compared with what we've got. A number of us have been running cardiac arrest registries, and I'm very privileged to work in a service where we've got a very established registry. Just point out, nothing to do with me. There is a team of far smarter people who run that than I am. And that is absolutely important, that we're looking at our data, we're understanding that data, and we're using that data to improve. I think as we go forward with OCA, what we're capturing has to be comparable. It allows us to look at system improvement. It allows us to do both research and quality improvement methodology with that data to look at how we find areas to develop. I think what we've got to now start to do is try and align, because I don't think inner city London is that different from inner city Manchester. So if we've got something working in Manchester, why on earth am I not doing it in London? We should be looking at systems around the world to compare and think, what are people doing that really makes a difference? And we should be absolutely looking at, as an ambulance service, to empower the community to make sure that we are out there looking at all of this that's going on, saying, right, what is it that works? And in order to do that, you need data, and you need data in a consistent format. We need to be doing that as we are with public access defibrillators through the circuit, so we can look at where we've got depths in defib position. We should be absolutely mandating where we can legislation that empowers defib placement. Yeah. And we should be using data to drive that. Why on earth can you build a block of flats and not put a defib in it in the 21st century? We wouldn't dream of building a flat and not putting a fire extinguisher in the flats or having a fire escape system. Why can't we do that with defibs? So we absolutely should be doing that. These are, we should be using data to absolutely challenge all of that. And we should absolutely be growing our collaborative data settings to make sure we're looking at what we can use and what we can learn from each other.
So just finally, Mark, as we finish off on the conversation, could I get you to speak to maybe indeed some of the future of cardiac arrest survival, and indeed maybe what you see as maybe some of the most exciting or indeed innovative developments in cardiac arrest management to further improve survival rates?
So I think there's one bit of this is every time somebody talks about cardiac arrest being a disease, my kind of vein in my head starts to throb and I start to feel a little bit ill, and then I very close to having a cardiac arrest, is that it's not. Cardiac arrest is the end stage pathology of many disease processes. And actually what we need to do is look at this in an advanced way, that actually we're nuancing our care for the patient in front of us. And there is lots of stuff now about saying we probably need to be more individualistic in terms of the care we're delivering. How do we know that CPR in Owen is really working? What are our measures that tells us that chest compression is producing a diastolic blood pressure greater than X, that we know he's got coronary perfusion? Is that intra-arterial access? Maybe. Or is that just old technology? Or should we be looking at things like beat by beat blood pressure monitoring? And how does that fit into cardiac arrest? How do we, in that post-ROSC patient, decide that patient who needs to go to their local versus a hyper-invasive strategy? There is vast numbers of studies now around that look at where we should take cardiac arrest patients who don't have a STEMI on their ECG. And perhaps some of that we need to individualise and look at, actually, are there factors that might indicate somebody who would be more in line with a hyper-invasive strategy? And should we individualise that care? How do we treat the patients as well as the algorithm? And how do we individualise advanced life support? And that's a different skill set to what we might be currently teaching right now. And how do you how do you kind of nuance that resuscitation algorithm, which we all wrote for very good reasons, because we all want to be really good at it and slick at it. But how do you then say, and this is what we do? And then the final bit of which is about how do we empower society? How do we get defib technology into the sorts of things that the next electric car you buy, as well as it's got your warning triangle and your first aid kit in the boot of it, how does it have a defib in the boot of it? How do we get defib technology that's the sort of thing that people would be happy to have in their house, and the price that could you have in the house? How do we have political conversations and say it's completely unacceptable to build a building and not put a defib in it? And how do we do all of that in a really nuanced way? So I think the future of this is around individualised care and a society response. And I think we come back to, this is about a community that responds as well as an ambulance service that responds.
Listen, that's powerful, Mark, because like you said, and that's a mindset shift, but one which absolutely needs to be made, because it's you're right, to shift the needle and indeed to address all those pillars, those 4 pillars of the chain of survival. It's going to take society, it's going to take the whole community in a very targeted, nuanced way, reduce friction amongst multiple points to do that. And as you said before, through the data will inform the improvements, because that absolutely is unequivocally something you can't argue with. Mark, listen, it's always a pleasure to talk to you. It's always a pleasure just to unearth things from your perspective. So thank you for joining me tonight.
Thank you very much.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.